Welcome everyone to our September guest speaker with Dr. Handy. So we'll get started in a few minutes, so feel free to say hi in the comments.
Nana, this one's mine.
Okay. Welcome Alliance HOSA members to our virtual meeting with Dr. Handy. Good evening, I'm Madhu. Just to introduce myself, I am one of your sophomore council members, and I am stoked to be here tonight.
Hey guys, I'm Rutu and I'm one of your committee leaders, and I'm also very excited to be here and have everyone meet Dr. Handy. And so just as a reminder, we are going to keep a QR code for attendance at the very end, so just make sure to stay the entire time.
Before we begin, I'd like to briefly introduce our CTSO/organization to any of our new members. HOSA is a student-led healthcare organization that strives to prepare students for the future of healthcare. Through Alliance Academy's HOSA chapter, we bring you monthly guest speakers with a wide range of specialities and from all around the globe.
So now, without further ado, tonight's guest speaker is Dr. Handy, and on behalf of Alliance HOSA, we welcome you with warm and wide arms. So thank you so much for joining us. We are really, truly honored. And so we're going to go ahead and start off the discussion, and we will have some opportunity for member questions towards the end of the event. So that does mean that the floor is open to any questions. So you guys can go ahead and type them in the chat box. So Dr. Handy, why don't you go ahead and just introduce yourself and tell our members a little bit about your field?
Okay. Again, Dr. Kendall Handy. I'm a practicing obstetrician gynecologist here in Columbus, Georgia. I went to medical school at the University of Alabama in Birmingham, and that was for 4 years. After that, I did my training in obstetrics and gynecology at Sinai Hospital in Baltimore, Maryland. After I finished that training, I moved to Atlanta. I came to Atlanta, Georgia, and practiced general obstetrics and gynecology for 18 years in Atlanta. And then after that, I moved to Columbus, Georgia, and I've been here ever since 2008. Now, the practice of obstetrics and gynecology is basically you're dealing with women's health. And there's a lot of variety in the practice of OBGYN. One is obviously the first thing that people think about is delivering babies. So that's one aspect of my practice. It's a big part of my practice, delivering babies. And in doing that, our job is to try to get the healthiest baby we can get and also have the healthiest mother that we can get. The other thing in obstetrics and gynecology is the gynecology side. And when you think of gynecology, you're going to be thinking about doing hysterectomies. We do tubal sterilization. We remove ovarian cysts. There are different surgeries that we do in the pelvis that are gynecologically related. We also do preventive care, such as when you hear the term Pap smear, that's where we're trying to prevent or catch a cervical cancer or try to prevent somebody from developing cervical cancer. We also do medicine. We have patients that may have an infectious disease. That's also a part of obstetrics and gynecology. So one of the reasons I decided to go into obstetrics and gynecology is because of that variety. You have medicine involved with it. We have patients that may have hypertension or diabetes and they're pregnant. We deal with that. There's infectious disease. We deal with that also. There's surgery, whether it's a hysterectomy or there could be an ovarian mass that needs to be removed. There's that. Then, of course, we have the fun part of we get to deliver babies. Now, most babies fortunately come naturally. That would be having a spontaneous vaginal delivery. But a large part of the surgery that we perform is cesarean sections. And probably a third of our deliveries are cesarean sections. And that's a big part of what we do. But that's usually needed because to get that healthy baby and that healthy mom, sometimes a cesarean section will have to be done. That's sort of, it's a broad area. I'm considered a general obstetrician gynecologist. You can go do your 4 years of residency in obstetrics and gynecology, and you may decide that you don't want to deliver babies. So you may do a fellowship in urogynecology. That's a physician that specializes in the urinary tract of the female with regard to prolapse, urinary incontinence, that type of thing. Or you may decide that you like the medical aspect more, where you become a maternal fetal medicine specialist. That would be another 3 years. That's a fellowship where you're dealing with high-risk pregnancies predominantly. You also have the reproductive endocrinologist. That's somebody that specializes in getting patients pregnant. If a mother's or an individual has infertility, where they've been trying to get pregnant for a year or more and can't, then they'll go to a reproductive endocrinologist or infertility specialist. That's all part of OBGYN, but that's further training. Then you have somebody that specializes in just the female cancers, uterine cancer, cervical cancer, vaginal cancer. That's a GYN oncologist. That's another subspecialty. And again, these things are done after you've done a residency of 4 years in general obstetrics and gynecology. Then you do an extra fellowship, usually 2 to 3 years more for those specialties. So reproductive endocrinology, that would be infertility, GYN oncology for cancer, maternal fetal medicine if you're dealing with high-risk pregnancies, urogynecology if you want to specialize in the bladder and incontinence and also prolapse. And let's see, is there anything to add to that? Basically in my practice, like today I went to work, I rounded with the residents. I teach both, I teach family practice residents here in Columbus. In Atlanta, I taught OB residents also. We also teach medical students from Mercer and Pennsylvania School of Osteopathic Medicine and Virginia School of Osteopathic Medicine. And so we round with the residents in the morning. Then what I'll do is I'll check labor and delivery to see if I have somebody in labor for that day. After that, I'll go to the office, which I was in the office today until about 4, maybe 4:15, and seeing patients, both OB patients and GYN patients. And I came here, and here we are.
Okay, so yeah, there's definitely a lot of diversity in this field, as you've said. So how did you choose kind of what aspect of gynecology you wanted to go into?
That's a good question because a lot of my medical students who are trying to decide what they want to go into ask that question. I narrowed it down. When you go to medical school, there are 5 core things that people might go into. One, it might be internal medicine. One of those cores is obstetrics and gynecology. Another core is psychology. Another core is general surgery. And the other one would be pediatrics. And so from process of elimination, I eliminated pediatrics. Not that I don't like kids, but I eliminated pediatrics. Then I eliminated psychology, very important field, but I didn't want to be a psychiatrist. I narrowed it. I liked surgery, but I didn't want to do just surgery and work from referrals all the time. Family medicine was very interesting because it had a lot of variety. In family medicine, you can do deliveries in family medicine. You can take care of the pediatric patient, you can take care of the adult patient, a lot of variety there, and you do a lot of medicine, but not as much surgery. I narrowed it down to family medicine and obstetrics and gynecology. I decided on obstetrics and gynecology because, number one, I could do medicine, I could do surgery, I could deliver babies. Pediatric patients, not so much. Occasionally we'll have a patient that might be 13, 14, 15. They may have an ovarian cyst that needs to be removed. But the variety was there where I could also do both surgery and I could deliver babies and do medicine. Actually, infectious disease also. So that's why I chose obstetrics and gynecology.
Okay, yeah. So one question I did have is what's sort of like the relationship between obstetrics and then gynecology? And do you have to be specialized in both or could you pick?
Good question. Usually you do your residency and you will be trained in both obstetrics, which is delivering babies, doing cesarean sections, and also gynecology, which could with different surgical procedures, which are hysterectomies, removing pelvic masses, that type of thing. Once you've done that residency, you can decide that you want to go down the path of no deliveries at all. Let's say you don't like being up at 3 o'clock in the morning to deliver babies. You can decide to do gynecology only from the very beginning. Or you can be in practice for a while as an obstetrician gynecology and just decide, well, I've been doing this for 10 years. I've been delivering babies for 15 years. I want to just do gynecology now. And you can do that. So you can, once you go through your residency, you kind of get a flavor for what you'd like to do for the next maybe 30 years or 20 or 30 years. Some people, they decide very early they only want to do gynecology or they want to subspecialize in one of the other fields I talked about earlier.
So Dr. Handy, what does a day-to-day look like for you?
Okay. Mondays, the way we have it broken up right now between my partner and I is Mondays and Tuesdays, I'm on call for deliveries during the day. Wednesdays and Thursdays, my associate is on call for deliveries during the day. Friday, we alternate who's going to be on call during the day. The person that's on call will come in, round with the residents, and they'll be on call for any person that comes in labor that day. The person that's off call that day usually is playing catch up. They're catching up on the records, that type of thing. And once they're done, they're done. They pretty much have the day free. Now, my typical day, let's say Monday, yesterday, was coming in, rounding with the residents, and that means seeing the different patients that are in the hospital, checking to see if somebody's in labor. And then if nobody's in labor, I will go to the office and I'll be there probably seeing patients from 8:30, break for lunch at around noon, start seeing patients again from 1:30 to roughly around 4 o'clock. During that time I'm seeing patients, I'm also teaching family practice residents and medical students that are there. Then after that, if I'm not on call that night, then I'll come home, have a nice dinner, and just have a nice relaxing evening. Today was pretty similar to yesterday. Residents in the morning rounding, came to the office, saw patients during the day, and I wanted to get out of the office early enough so I could set up and talk with you good people this afternoon. Tomorrow, Wednesday's our surgery day. That's important. Wednesday's a day that's set aside for us to do nothing but operations and surgery. That's the day we normally do robotics. We do our robotic hysterectomies. We do different laparoscopic procedures. We do something called a DNC, where we take we scrape the inside of the uterus and get tissue samples to rule out cancer. And if we have surgical cases that day, usually it's 3 or 4, we get those cases done, and then we're pretty much finished for the day. If there are no cases, then we pretty much will come in, we'll round with the residents, and then we'll play catch up with regard to whatever charting we need to do in the computer system. Thursday is another day of patients. Friday, as I said earlier, if you're off that Friday, then you can have an early weekend. If you're on call that Friday, then you'll come in, round with the residents, and you will really pretty much be waiting to see if somebody comes in labor, and you'll do whatever deliveries need to be done that day. Now, the other part of what we do, because we deliver babies, is we have a call system. We're not on call every night. So last night was my partner's, my associate's night to be on call. So that means anybody that came in after 5 o'clock until 7 o'clock the next morning, he would take care of those deliveries. Tonight, we have another physician that's on call to do that. Tomorrow night, I happen to be on call. So we'll do whatever surgeries come through tomorrow. And then starting at 5 o'clock, I'll be on call from 5 until Thursday morning, 7 o'clock in the morning, such that anyone that comes in labor, I will take care of those patients. And that rotates. Right now, I probably do maybe 1 call night a week. And traditionally, we do 1 weekend call a month. We do a Friday night, Saturday, and Sunday.
So when you are like in the process of like delivering a baby, what are like your like deciding factors on whether you like help the mother deliver it naturally or perform a C-section?
Most of the time, patient comes in labor, and our goal always is to have a vaginal delivery and a healthy baby and a healthy mother after that. But what happens is sometimes the baby may get into trouble where the baby may not be getting enough blood supply or oxygen, such that you have something called deceleration, where the baby's heartbeat drops. And if that happens enough repetitively, then that baby could have hypoxia, which is a decreased amount of oxygen getting to his brain, and you can end up delivering a baby that has problems. We want to prevent that from happening. So if we see signs such as repetitive decelerations or any signs where the baby, if it continues in the mother, if the baby continues in the mother, it's a bad environment and the baby could be damaged, we're going to need to do a cesarean section. The other thing is sometimes the mother is extremely sick. If the mother is extremely ill, there's a term you may have heard, it's called preeclampsia or eclampsia, where the only treatment for that disease process called preeclampsia, the only treatment is delivery of the infant. Well, that's another reason why we'll go ahead and possibly do a delivery or do a cesarean section to go ahead and end the pregnancy so that baby can do well and mother can start improving or get well herself.
So, what was your first impression of this field before you started getting interested in it? Was it anything like you expected it to be, or was it very different from what people told you it would be?
Good question, because a lot of students, when they rotate through on the rotation with OBGYN with myself and my associate, they have no idea what they're getting into. And actually, some of them didn't think they would like it because they didn't realize the variety that's associated with it. I think for me, going into medical school, I really did not have a feel for what area I wanted to go into. I thought maybe a family medicine at one point in time, but I really didn't go into in my first year of medical school, I did not know whether I wanted to be a psychiatrist, an obstetrician gynecologist, pediatrician, surgeon, none of that. And it was through doing the different rotations. The rotations we used to have were either 8 weeks to 12 weeks. And so on that rotation, you can see what you would actually be doing usually if you decided to go and do a residency or practice. So you rotate on OB for about 8 weeks. You rotate on internal medicine for about 12 weeks. Psychiatry, I probably did maybe about 6 weeks on psychiatry. Pediatrics, we probably did about 8 weeks. So you can get an idea of what you're going to be dealing with, from what kind of patient you're dealing with, how much surgery will you be dealing with, how much of that area will be dealing with medicine, what's the lifestyle with regard to sleep, that type of thing. So after a while, you kind of can get an idea of, well, I don't want to do that because I don't like that particular aspect of it, but I do like this other aspect. I like the surgery part, or I like the medicine part. And then you narrow it down to that area that you're comfortable or you're more interested in.
So we actually have some member questions. So she asks, how does new technology affect your field, or how has it affected it?
Great question. The new technology has really, and specifically, I would say robotics.
Mhm.
Doing robotic surgery has affected our field because patients have gotten larger. And when you're working on a smaller uterus, it's easier, I think, to do some of the procedures we do with the robot versus having to make a large incision on that individual's abdomen. That technology has helped to reduce, number one, it's helped to have patients go home the same day. It's helped to reduce them from having a large wound infection. It's also helped patients to get back to work a lot faster than they would versus when we had to open the patient up with a large incision in the lower abdomen. So that technology, specifically robotics, has helped considerably. It's also helped not only just robotics, but over the last 30 years, I've been doing this for over 30 years now, some of the instruments that we use that control bleeding have really benefited a lot. And it's also helped us to get through with the surgical procedure faster and easier because of that technology.
So based on the type of procedures I know that you do C-section, but what other kinds of procedures do you do in your field, or like surgical procedures, I mean?
Oh, the other procedures, some of your minor procedures one is called hysteroscopy. Hysteroscopy is where we actually can place a scope, it's called a hysteroscope, up inside the uterus, and we can look for any abnormalities that might be up inside the uterus. That's called hysteroscopy. Another procedure is called laparoscopy. Laparoscopy is where we may make a small incision in the umbilicus or in your belly button that is big enough for an ink pen to go through. And through that small hole, we can place a scope. It's called a laparoscope. And we can see the patient's ovaries, the fallopian tubes, their uterus. We can look up at the gallbladder, the liver, see their intestines, but that's from a small puncture site big enough for an ink pen to go through. We do something called D&Cs. D&C stands for dilatation and curettage. That's where we take an instrument to dilate the cervix. The cervix is the opening to the uterus. And after we dilate the cervix, like here, you dilate the cervix, then we can take an instrument to go up inside the uterus, and we can scrape tissue out of the uterus that we might be concerned with that might be cancerous tissue. That's called a dilatation and curettage. The other procedure we do is some people, they may have what's called a partial or incomplete miscarriage, such that there's tissue still in the uterus that needs to be removed. That procedure is called a suction dilatation and curettage. That's another procedure that we do. And then we can do biopsies. Sometimes a person may have a lesion on the outside of the vagina where we have to do what's called a vulvar biopsy. we do a vaginal biopsy or cervical biopsy. Those are all procedures where we're removing a piece of tissue, and then when we do that, there's going to be bleeding. So then we have to stop the bleeding. And then, of course, robotic assisted procedures, robotic assisted laparoscopy, where we use the robot to assist us in doing things such as hysterectomies, removing ovarian cysts. You can do myomectomies. Myomectomy is removing what's called a fibroid. That's a growth within the uterus. Removing that because that can help reduce a patient's bleeding, help reduce some pain they might have. But that can also be done with robotic laparoscopy or robotic myomectomy. That's robotic surgery that we do. And we also do, you may have heard tubal sterilizations. If a mother has they've had their children and they want to have permanent sterilization, we do laparoscopic tubal sterilization.
Okay, yeah, got it. One of our other members had asked us, what is the education and schooling required to become an OBGYN?
Okay. What I know everybody's going to do here is finish high school and graduate. Then from there, what I did, which most of us do, we go to college. You don't have to major in pre-med. There are some prerequisites that you definitely should take. I mean, you can major in something else, but there's certain biology and chemistry that you need to take. I majored in zoology, but you can major in biology, chemistry. And so for me, because I changed majors, I did 5 years, but basically you'll get your undergraduate degree at university. And then from there, you apply to medical school. I went to 2 colleges. Actually, I went to High Point College for 2 years. And then at that time, I was majoring in accounting. Then I transferred to Alabama A&M University in Huntsville, Alabama. And that's where I changed my major to zoology and graduated with a Bachelor of Science degree in zoology. And that's when I applied to University of Alabama School of Medicine. And medical school is usually 4 years. So you're looking at your 4 years of college, then your 4 years of medical school, and then an OBGYN residency is 4 years.
And sort of a follow-up question I've had is I've talked to some med students and I've heard like different things on taking a gap year between your undergraduate and your medical school. I want to know what your opinion on that would be.
It's very individual. I'm one of those, I'm ready to get it done. And I was one where I'm in the habit of studying and being in that study mode, but that was me. So I went straight from graduating from college straight into medical school. Finish in May, start in July. Some people may take a gap year. They may need a break. Some people may take a gap year to do some research. They may take it to travel. That's very individual, very individualized. It's not you don't need to do that or you need to do this. That's up to that individual.
Another question one of our members had is, what were the most important experiences you had in college that helped you prepare for the field?
Studying a lot. I think that when I was in college, I think I remember taking, I think I had analytic chemistry, organic chemistry, calculus, biology, all these courses all at the same time, probably 5 hardcore courses at the same time that I was studying in. Now I loved it. I would go ahead. I will accept the nerd, the nerd hat. But just getting in the habit of sitting down, putting your head to the grindstone and studying, that helps you a lot. I did a little bit of research also, but when I was in college, I would probably get some of those last couple of years, I probably would get maybe 4 or 5 hours of sleep just because I was studying. I was up till, now the only reason I was up till about maybe 1:30, 2 o'clock studying, then get up and do a little research at 6 a.m., 6:30, then go to classes. And then I also had a job afterwards. I worked at the grocery store in the evenings. So that, and then when I got home from grocery store, then I would study. But I think the biggest experience for me in college getting me ready was just I was in the habit of studying, and so that's the thing. The other thing you have to remember is if you want to do it, you'll do what you need to do. You'll study what you need to study. You'll put in the time you want to take in. That a lot of determining whether you want to do something or not is whether you're ready to jump the hurdles or not. So it's what I wanted to do. So I did it. But definitely in college, studying a lot and getting being in the habit of studying, that helped me in medical school.
I was wondering, like you were saying, you had to juggle a lot of things during both your undergrad and your med school. What are some things that you use to like kind of manage everything? Because I'm sure that a lot of our members who are in a high school are also trying to juggle a bunch of things all at once. So do you have any like advice for that?
I think biggest advice is and I've read this before, you have to set aside time to do the things that need to be done. And actually even set aside time to do those things that you want to do. But if you don't put it in a schedule or on a calendar, then you're kind of up to the whims of whatever your emotion pops up that day. And if you wake up and it's raining, now you're going to feel down. If you wake up and it's snowing, you feel down. If it's sunshine, you feel good. If you hear people that are professionals talk, they'll tell you they're a professional because they do what they need to do, whether they feel like doing it or don't feel like doing it. That makes them a pro. A writer writes, they don't wake up in the morning and go, I really don't feel like writing today. It doesn't matter. They're going to write because that's what they're professional. That's why they write. The same thing in school. When you're going off right now, when you're getting ready to go off to college or right now in school, you need to set aside time. You need to say, hey, it's Saturday. Like for me, I would say, okay, it's Saturday morning. The game's doesn't start until 3:30 that I want to see. I'll sit down from 9 to 11, study, take a little 15-minute break, study from 11 to 1. I mean, you just know that's what you're going to do. And then you have your enjoyment, you watch the game, but then you may say, 8 o'clock, I'm going to study. But put it in a calendar, and then you have to just sit down and do what you need to do. But don't wait till you feel like doing stuff. Don't wait. You need to go ahead and do what you need to do because feelings are fickle. I mean, most of us didn't feel like getting out of bed today. So we got out of bed. You have to do what you need to do in those times. But create a schedule that works for you. I did well studying at night. Did real well studying at night. First thing in the morning, I do well at studying. In the afternoon, I get really sleepy right after lunch. So you have to kind of find out what is a time that you really know that you're going to study well. You're not going to get sleepy. You're going to be really motivated. Find that time that works for you, but you have to stick to it. And real quick, discipline is your best friend. Discipline is your best friend. Discipline means you do what you need to do, whether you feel like doing it at the time or want to do it at a time. You make yourself do what you need to do.
Yeah, that was some really good advice. Another one of our members had asked us, why are some babies born premature when compared to others who are born later?
We've been wrestling with that question for a long time, why some patients go into premature labor and why some don't. We really don't have a good answer. Now, we know there are certain things that can increase a person's risk for premature labor. Like if someone's 24 weeks pregnant and their water breaks, they're going to be at risk for premature birth. But as far as having two very healthy patients, they're the same age, same backgrounds, why one delivers prematurely and why the other doesn't, we don't have a good answer for why that happens. There are some things that can happen. Certain infections can develop in a patient. If a patient has a kidney infection, that can increase the risk of going into preterm labor and delivering preterm. Certain illnesses, preeclampsia I talked about earlier, sometimes those patients have to be delivered premature because that's the treatment of that disease process. But as far as if you have two patients, they have absolutely no risk factor at all, why one goes into preterm labor and the other one doesn't, we don't have a good answer for that right now.
And what happens if a baby is stillborn?
If a baby is stillborn, we still have to deliver that baby. We usually will induce labor for that patient if that's their desire. Inducing labor means that we put the patient in labor. There's certain medications we use to help prepare the cervix, which is the opening to the uterus for that. And then we have a medication that's called Pitocin that causes the mother to have contractions. And then we hope to get a vaginal delivery in that situation. Sometimes we do have to still do a cesarean section. And the mother, depending on her emotional state, could actually ask to have a cesarean section in that situation. We would prefer a vaginal delivery simply because there's less risk for infection and blood loss if we do a vaginal delivery.
And another one of our members had asked us, what is the toughest part of your job?
Well, the toughest part is if you have to tell a mother that they have a stillborn. That's very tough. When you have to do that, we always listen to the heartbeat on patients when they come in for their normal, it's called a prenatal visit. That's one of the first things we do is ask them, is the baby moving? And when they say the baby's not moving, I start getting a little anxious about that until I can hear the baby's heartbeat. But when one of the hardest thing, that's probably the toughest thing, is when we have what's called a bad outcome. Bad outcome means that we don't get that nice, healthy baby that we know the parents want to have. The other toughest part is if you have a mother that dies. It's called maternal mortality. That's one of the toughest parts of the job. Really, is baby dies or mother dies, or is significantly harmed in any way. That's where that's the toughest part of the job.
Yeah. How have you learned to deal with that? Having to, I'm sure like that you've gone through that in your career. How have you learned to go through that?
I think that I'm not sure if you learn how to go through with it. I think you first of all, you have to accept what happens. One of the things you do is you try to figure out, was there something I could have done better in the situation? And oftentimes there's nothing. Certain things that happen in nature, they just happen. You deal with it if you have a faith. Yeah, you deal with it with regard to that. If you're a spiritual person, prayer helps you to deal with some of these things. You have a faith. I think that's probably a big part of it. One of the toughest things that I had to deal with is where a mother was shot. She was basically shot in the head, and she was pregnant and had a baby that was pretty much near term. When she presented to the emergency room, they're basically doing CPR. Well, the mother died, was able to deliver the baby, and the baby's still living at this now. I mean, the baby that's probably possibly 13, 14 years old now. That's very tough because we're not used to having mothers die in that kind of situation. The other thing is I've assisted on a case where similar kind of situation of violence where the mother died and the baby died. That's very difficult. And that's one of those situations where it's traumatizing and you really need to talk. First thing you need to do is you have to talk about it with people. When I've had these things happen before, sometimes we actually have to sometimes you should talk to the psychologist, or you talk to the pastoral staff at the hospital to kind of talk through it and say, what are you feeling? What's going on? How are you feeling about? I mean, obviously you feel bad, but just talking about the situation, because the nurses who are helping to take care of that patient, they're affected by it. The physicians are affected by it. Any other technicians that are working to try to deal with that situation is difficult. But The worst thing to do is keep it in and to not talk about it. You need to talk about it, talk about your feelings about it, and go from there. Not something you actually want to get used to. I think it always should bother you some. When it starts to not bother you, maybe time to retire. But it usually, most of those things will bother you. And then, of course, it comes with the territory. Good thing is, most of the time that doesn't happen. That's a good thing.
Yeah, thank you for that. I mean, no matter wherever our members go in the healthcare field, death is something that they're going to endure. So it is helpful to kind of know like how to deal with that.
Yeah.
And I did want to ask that we were kind of talking about this before, but how has COVID affected your field specifically?
Wow, that's a good question. One of the things that it affected some probably was people getting their routine exams because they may not have been coming to the office because of COVID. In other words, they may not have gotten a mammogram on time. They may not have gotten a routine Pap smear on time. Of course, you are exposing yourself to the patients, and the patients are exposing themselves to you with COVID. So one of the things we had to do was not see as many patients during that time. At first, when you had the initial shutdown, we did not see as many patients. And if you had an illness at all, if you were felt to have COVID, you really were not to come to the office. Of course, we had masks on the entire time. I probably delivered some patients. I don't know what they look like. They probably had the mask on for the whole 9 months. So if they removed their mask, I may not know them if I saw them in the hallway. But the masking was a little, we all got tired of wearing a mask, basically. And when I'm trying to talk to residents and students and patients, talking with the mask on was a little, after a while, it gets uncomfortable. Now, some patients who actually had COVID that we delivered, I would have to don, obviously I've had my scrubs on, but then we'd don a whole nother, we call it like a bunny suit, was a whole nother suit that you put on top of your scrubs. Then you'd have on an N95 mask on. Then you have the mask over the N95 mask. And when you're operating with that on, it can get extremely hot. But that was one of the sacrifices we needed to do in order to protect ourselves from getting COVID from the patient. And that was, fortunately, I didn't have to do that, but maybe 2 or 3 times during the last 2 years, fortunately. But I did know there are physicians that they had to wear the N95 the whole time they were at work, especially your ICU physicians. So it affected us. And we had certain areas where patients had to go to be isolated if they were COVID positive. And then if we knew they were COVID positive, we would have to don all of the personal protection to protect ourselves from getting it.
Are these restrictions still in place today, or have they eased up a bit?
They've loosened up. Now we can, it's if I want to wear a mask all day within the hospital now, I can. If I know I'm going to be exposed to or going into a room or a patient is COVID positive, I'm definitely going to wear a mask. But I don't have to wear a mask in the office now unless I'm feel uncomfortable about a patient that may have COVID. So it's been loosened, thank goodness.
So what is one general piece of advice that you would give to someone who's new to OBGYN?
Now, I want to make sure, is that somebody who's interested in going into OBGYN, or they're
new to OBGYN?
New to OBGYN.
They just started.
You mean starting a rotation?
They didn't specify, but
starting a rotation, or maybe like someone who's interested in being
OBGYN. I think that the big thing is because there's variety, expose yourself to all the different procedures that you can. If you see a particular patient that has a particular disease process, and I tell this to no matter what rotation you're on, whether it's on medicine or surgery, whatever disease process you see and you have a patient with that, that's that night you want to read about that. That's the best time to read about that particular disease process because you can attach it to something that you've already seen. But the key thing, if you're new to OBGYN, is expose yourself to deliveries, expose yourself to cesarean sections, the different varieties of patients that you can see, expose yourself to that, and then read about it after you've seen it. I think that helps a lot.
Okay, yeah, got it. And one of our other members had asked us, what is your favorite part of being an OBGYN?
Let's see, favorite part. I like the patient interaction.
Yeah.
I'm kind of a jokester. I like to kid around with the patients and I like to know where they're from, what they're doing in the world, what they're doing in life, what their kids up to. I like to tease the fathers that come in there, the first fathers that come in there. I like to enjoy at the time of delivery, talk to, when you have the father and the mother there, just sort of tease with them a little bit. I always tell them you're getting ready for the on-the-job training now with their new baby. And I think that the patient interaction is probably that's the part I think most of us like more than anything. Is just the interaction with patients. And obviously if they have a problem and you can help them solve that problem, if it's a medical illness or whatnot, you can help them get over that and get past that. That's extremely rewarding. And then at the end of the day, if you can get them through a pregnancy and they deliver a healthy baby and mom goes home healthy, baby goes home healthy, that's extremely rewarding also.
Is there like a specific case or a specific patient that like sticks out in your career that you like most remember?
Wow. That I most remember.
Yeah.
I don't think there's been a lot of different patients that have been interesting. Unfortunately, the things that stick out are the ones that are the really bad things that can happen. Unfortunately, like I mentioned earlier with the gunshot wound and the violence that occurred, those are the ones that stick out. And the good thing about that is 99% of the time, that's not something I have to deal with 99.9% of the time. Fortunately, most of the time I'm dealing with happy mothers. We have healthy babies, and occasionally we have some difficult cases, but we work those through. And if I can't handle it, then I'll try to get them to a physician that's their specialty or that can handle it for the most part. But that's what I remember mostly. Unfortunately, I remember the bad cases, unfortunately, but fortunately there have been few and far between.
So how would you briefly describe a day in the life? Like just every day.
Every day in the life. My day in the life starts at 6:30. I'll usually get up at 6:30, get up, get dressed, try to leave the house at 7 o'clock. Takes me 30 minutes to get to the hospital. So when I get to the hospital at 7:30, I go and I find a residence. We usually meet on a particular floor of the hospital. They will have a sheet that has all the patients that myself and my associate are responsible for that day. And we'll then we'll talk about those patients. Then usually I'll go from room to room, pretty much like you see on television sometimes. I'll go from room to room and see how those patients are doing. And then we'll set up a game plan for whether that patient's going to be discharged home or whether they need to have a new medication started or whether we need to go ahead and have them delivered. But we'll set up a game plan for each one of those patients. That's usually, it takes within an hour that's done. By 8:30, I'm usually going over to the office. The office is right across the street from the hospital. And I'll see patients that are usually scheduled every 15 to 30 minutes. And I'll see patients till about noon. Then a lot of times I'll play catch up at lunchtime. Sometimes I'll eat very minimal amount of lunch. Sometimes I'll actually go for a walk during lunch. If I don't have any catch up, I'll just go for a walk, put in a mile walk. And then starting back at 1:30, I'll start seeing patients again every 15 to 30 minutes until around 4 o'clock for me. If nobody's in labor, then at 4 o'clock, 4:30, I'll wrap things up, try to clean it, get all of my charts signed off. And then sometime I'll go to the YMCA to work out. I'll go down. We have a river walk. I may go for a walk. And then from there, I'll come home. Then I'll come home. And sometimes my wife is out of town. She's up in Atlanta. Sometimes she may be doing work up there. And I will start cooking. That's part of my relaxation is cooking. And since I'm using knives, I cook real slow and I cut real slow because I can't afford to cut my fingers. So I'll cook and she'll get home, 6:30, we'll eat dinner. And then we have 2 little puppies at the house that we play around with. And then we'll watch maybe something on television. I'll do some reading. I like to read. And then I'll usually be in bed by 9:30. Our puppies make us go to bed because they're ready to go to bed at 9:30. So we go to bed at around 9:30, maybe do a little reading in bed. So by 10 o'clock, I'll go to bed and go to sleep. Now, if I'm on call, I may put my head to the pillow at 10 o'clock, and at 10:15, labor and delivery may call me and say that Miss So-and-so is in labor and she's in active labor. I may have to get up and go to the hospital. So I'll drive into the hospital and I may do a delivery during that night. And if it's too late, a lot of times if it's after 2 o'clock or 3 o'clock, then I'll just stay at the hospital and just start my day all over again the next day.
So when you're on call, are you staying at the hospital or are you staying at home, or like does it depend on which day?
It really depends on how busy you are. When I was in Atlanta practicing, our practice was extremely busy such that we stayed in the hospital. We would come in the morning and stay in the hospital until the next morning. Then we would go home the next day because we were probably going to be up at 1 o'clock, at 4 o'clock in the morning delivering babies. We also covered the emergency room at that time. What I've done here is usually I'm at home, but if I have to go into the hospital, well, basically, let me back up. Now, basically, I try to be at home even when I'm on call. But if I know that the person's going to deliver soon, like within an hour or within 30 minutes, definitely, I'll usually go to the hospital. And depending on what time of the morning it is, if it's 4 o'clock in the morning, I just did the delivery. I'm not going to drive back home because then I'll be turning around 2 hours later driving back. So then I'll take a nap at the hospital and then start my day at 7:30.
Yeah, so it's a pretty packed day to day.
Right. Now, one of the things that's interesting now is we have what are called OB hospitalists now.
Mhm.
Now, OB hospitalists, they're general obstetricians and gynecologists, but they specialize in being in the hospital, covering unassigned patients. These are patients that haven't seen a physician yet. And also they can do emergency deliveries for those patients. So like if I can't get to the hospital in time, they do emergency deliveries. Now they stay in the hospital for 24 hours. They come in at 8 o'clock and they stay there till 8 o'clock the next morning, but then they'll go home the next day. And they usually don't have office responsibilities, although some do, but most of them don't have office responsibilities the next day.
Yeah, got it. And one other member had asked us, what are some risky problems that you've seen in patients?
One of the risky problems is if the placenta is located basically on top of at the opening of the uterus, we'll put it that way. Well, the baby's supposed to come through that opening, such that if the placenta is there, then we do have to do a cesarean section. The problem is that patient, because of the location of the placenta, could start having heavy vaginal bleeding. And bleeding, you can lose a lot of blood in a pregnancy when the placenta starts to separate from the wall of the uterus. You can lose a lot of blood. That's one risky situation. Another risky situation is after a baby delivers, the uterus is supposed to contract down, not all the way down to its normal size right afterwards, but it does contract down, and that helps to reduce bleeding. sometimes the uterus is not as cooperative as we want it to be. And so the patient continues to have heavy vaginal bleeding such that they can become severely anemic and you can go into shock. So we use medications to get the uterus to contract down the way it should to help reduce that bleeding. So that's one area. Another area is if somebody has what's called severe preeclampsia, that's where a person has really elevated blood pressures, then that mother could have a seizure, and that can cause a problem. That mother could also, and with that seizure, you could also have a brain bleed. And also with preeclampsia, the placenta can separate from the uterus prematurely. So these are different risky problems that can develop in a mother that basically just got pregnant. And then there are certain infections that can develop just from doing a cesarean section. That's a risky problem. There's certain risks associated with being pregnant. Fortunately, most of the time they don't occur, but there's really bad infections that can occur just from having had a baby and having had a cesarean section. Most of the time they don't occur, but something called sepsis that can occur, and patients can die from that. And of course, we talked about postpartum hemorrhage. That means after the mother delivers, she has significant bleeding. Patients can go in shock from this, and that can lead to the death of a mother or mortality. And then sometimes a mother may have an underlying heart disease that can increase her risk just from being pregnant. So there's certain risks. There's certain areas. Sometimes as obstetricians and gynecologists, we always talk about pregnancy is not a benign thing. Benign thing is not just, most of the time things can turn out very well, but we always have to be ready for when things don't go so well or are not going as well as we would like.
So I was wondering, when was like the time where you realized that you wanted to go into gynecology and be an OBGYN? Like, was there a specific event that occurred?
Not really. I think what happened when I got to when you get to your third year of medical school, you start rotating through the different rotations early. You rotate through medicine, you rotate through OBGYN, family medicine, pediatrics, and psychiatry. And then once I did that process of elimination, it narrowed it down to family medicine and obstetrics and gynecology. Once I saw that I would be able to do deliveries, I was more likely going to do deliveries and do surgery as an obstetrician gynecologist. And that was after I did my rotation with OBGYN. That's when I said, okay, I'm not going to do family medicine. Great area, a lot of variety, but for me, it was lacking with the amount of surgery you would do and the amount of deliveries I felt I would do. And so really looking at the third year, in the third year after I did my rotation in obstetrics and gynecology, that's when I decided.
Okay, so what are some stereotypes about your field, and what's like the real truth behind it?
Let me see. I mentioned that. What did you say?
What are the stereotypes for your
stereotypes?
I know everyone has like a mental set of gynecology, so.
Stereotypes. I hadn't really thought about any particular stereotypes. I think a lot of people may think it's just about delivering babies and not realize the amount of fun that you can have with playing with the robot and operating with the robot, which is really a neat piece of technology. And I think the variety of procedures that we do, I think people don't realize that there are all those varieties of procedures that you can do as a gynecologist. And then I don't think people realize the variety of patients you can see also. But then they also don't realize that you can subspecialize in other areas if you decide, well, I don't want to deliver babies, but I like gynecology. They don't realize they could do gynecology only if they wanted to. Or someone may say, you know what, I don't like to do that much surgery. I don't like doing hysterectomies, that type of thing. You may decide to do reproductive endocrinology. You want to help people to get pregnant, but you may not want to do you may not want to do the delivery, but you really, really want to help people get pregnant, basically. So you become an infertility specialist. So I think that the people I think people recognize the variety that's in obstetrics and gynecology.
Okay, well, thank you so much, Dr. Handy, for your time. This has really been very enlightening for me personally, I'm sure for Madhu, and for all of our members, I'm sure. So I just want to thank you once again for joining us.
You're very welcome. Very welcome. Anytime. And good luck to everyone out there. And go OB.
And we'd also like to thank our members. Thank you guys for joining and making it very interactive.
All right. I'll see you guys later.
Bye. Thank you. And we
Bye
will.
now. Take care. Study hard.
Thank you.
So we're gonna leave the QR code for attendance we'll leave it up for like 30 seconds and you can get that scanned. And in order to get the guest speaker credit, you have to like scan it. It's due by October 28th. And this video will also be on our YouTube channel. So if you don't have a chance to scan it, just be sure to like skip to the end of the YouTube video and like scan it by the 28th. Otherwise, you will not get a credit. Thank you guys so much. Have a good night.
Thank you. Have a great night.